Okay, so up next we have Dr. Stephen Dunley, a visiting professor of neurology from the University of Colorado, speaking on the role sleep plays in memory and how it may affect the way our lymphatic system removes toxins from our brain. Dr. Duntley's interest in the science of sleep began at Yale University, where he studied the phylogeny of sleep. After graduating from the University of Washington School of Medicine, he completed a residency in neurology and fellowship training in sleep medicine and epilepsy at Washington University. There, he directed the sleep medicine program, which participated in research studying the interaction between sleep and Alzheimer's disease. At the University of Colorado, he treats patients with the full spectrum of sleep disorders, but specializes in the overlap between sleep and neurological disorders, and continues his involvement in research projects studying the interaction between sleep and neurological diseases. As a quick reminder, we will be holding the Q&A to the end of the presentation. You can submit those questions through the Q&A tab at the right of your screen. And with that, thank you, Dr. Duntley, for joining us.
Okay, and can everybody hear me okay?
We can, yes.
Okay, great. I'm going to talk about a really exciting area in the field of sleep. The whole field of sleep is relatively new, but understanding the interactions between sleep and memory is even more recent development. Every night, a remarkable thing happens. We start to go into stage 1 sleep, and can people see my cursor moving by any chance?
No, we can't.
Okay. Well, on the left side of the screen, you see rhythmic activity in the brainwave that disappears when we go into sleep, and the sleep becomes a irregular low voltage pattern, which is called stage N1 sleep. And if that's all you do, you really don't sleep very well. But as the night goes on, we begin to enter stage 2 sleep, and you start to see these abrupt, large amplitude waves called Cave complexes, and what are called sleep spindles, which are these tight little high frequency waves that occur during sleep. As the night goes on, we start to go into a deeper state of sleep, stage N3 sleep, which is also called slow wave sleep, where you have high amplitude voltage waves that occur and start to predominate and take up the whole record. And as the night goes on, suddenly there's an abrupt change, and the EEG starts to look much more like the waking EEG, but the eyes are constantly moving, and this is REM sleep. This is the stage of sleep where we do our active sequential dreaming. And then we go back and start the whole cycle over again. This is a hypnogram of sleep showing how we go into stage 1, 2, 3 sleep. Then we have a REM sleep. Then we go into stage 1, 2, 3 sleep again, REM sleep. Slow wave sleep predominates in the first half of the night, and REM sleep predominates in the second half of the night. And this is a pretty invariant pattern that humans go throughout their life cycle. The proportion of sleep changes, the timing of sleep changes. But we go through this cycle every night, and clearly performs important physiological functions in humans that we're just only now beginning to understand. The sleep is absolutely essential for the quality of life. It's one of the pillars of health, like diet and exercise. The consequences of inadequate sleep include sleepiness, impaired executive function and judgment. In particular, risk-taking goes up when you're sleep deprived. So it's not a good idea to go gambling or do other potentially dangerous things when you're sleep deprived because you really can't balance the risk-benefit ratio well. There's a decreased quality of life, impaired metabolism, increased inflammation, morbidity, mortality, and impaired learning, which is what we're going to talk about some today. There are functional consequences of impaired sleep. They include sleepiness, attentional deficits, and impaired memory. And they're structural. There's reduced lymphatic efficiency that we'll talk about later. And other sleep disorders confer additional risks for damage. For instance, with obstructive sleep apnea syndrome, there's significant hypoxemia. The blood levels of oxygen drop, which can actually damage tissues just because of the low oxygen levels. And when it comes to sleep and memory, there are a few things to remember. One is you can't learn if you're asleep. During a visit to a high school, a third of the students were asleep when they were having a visit by President Bush. And the people that were witnessing that were concerned about how many people would be sleeping during their calculus class if they couldn't even stay awake to see the president visit their high school. It's estimated that on any given day, half, perhaps more, are functionally impaired by sleep deprivation. So our ability to learn is impaired because we just can't stay awake. This is an example of what happens if you don't get enough sleep. The top line is how long it takes a person to fall asleep when they've had 9 hours of sleep the night before the testing. The bottom line is when you're up all night, you can actually fall asleep before your head hits the pillow. So you really need 7, 8, 9 hours of sleep to feel completely fully refreshed when it comes to staying awake. You also cannot learn if you can't pay attention to the task. And this upper left corner, look at that, the very left line is how often you don't pay attention to a light that comes on. The PVT test, you have to respond to a stimulus by pushing a button. And it's kind of like what would happen when you're in a car driving and you see a red light. You have to hit the brakes. And if you're sleep deprived a couple nights, you do very poorly in that. But also the second line, if you're sleep deprived for 2 weeks for 4 hours a night, it's like having 3 nights of no sleep at all. And so you're really unable to attend to tasks when you're sleepy. And this is cumulative. Even 6 hours of sleep a night can result in significant deficits when you do it for 2 weeks. So sleep is absolutely essential to maintain wakefulness and to maintain attention. I want to talk really briefly about memory classification. It's hard to describe how gross of an oversimplification this is. Memory is actually very complex, but it's still very useful. There's declarative memory. And this is like when you memorize the meaning of a word, you memorize things for class. Episodic is when you remember what you had for breakfast. This is easily accessible, discrete memory items that occur when we learn. Non-declarative memory is a type of learning that occurs without our conscious awareness that it's occurring. And that would like learning to ride a bicycle. When you do a math problem, you access semantic memories of how to do it. When you ride a bike, you just get on and do it. Procedural skills, learning to play an instrument, these are non-declarative learning tasks. Memory studies generally do 2 things. They look at post-training sleep deprivation and manipulation. For instance, they give a person a learning task and then don't let them go into certain stages of sleep, or they allow them sleep where they normally wouldn't, like a nap. Then there's post-training sleep modification. That's where you look at what's happening during a sleeping brain to see if it looks like what happens during waking. Studies have found that stage N3 sleep, that slow wave sleep, impairs semantic memory consolidation. So if you don't allow a person to get N3 sleep, they have clear and consistent changes in their ability to learn things like a list of random words that you give them to remember. Presumably, this is also the type of learning that you do when you do a history class. And so if you don't allow a person to get into stage N3 sleep, there's clear impairment of the memory consolidation. Also, interestingly, if you look at the electrophysiological or neurofunctional imaging studies, when you learn a particular task in the daytime and look at the pattern of EEG and neurophysiological and imaging studies, the activity patterns that you see during the learning task itself are repeated during stage N3 sleep. So it appears that the brain is actually rehearsing what you learned during the daytime while you're sleeping. So we used to think sleep was a very passive state. It's not. It's a very active state where you actually rehearse things that you did during the daytime. REM sleep, on the other hand, appears to be important for non-declarative memory tasks. Learning things, procedures, learning how to play an instrument would be more critically dependent upon REM sleep than slow wave sleep. The cortical reactivation patterns during REM sleep, if you look at neurophysiological parameters or you look at neuroimaging, a person recreates daytime learning activities during REM sleep, similar to those during the daytime. And so REM sleep plays a really critical role in procedural memory and non-declarative memory. And so the entire sleep cycle seems to be fine-tuning memories for different parts of the sleep cycle work to improve memory in different ways. The hippocampal sleep spindle connections appear to be involved in both declarative and non-declarative memory. So that stage 2 sleep that kind of fills in all the time between REM sleep and the slow wave sleep appears to also be involved in memory consolidation and isn't just there to fill up time. Not all memory consolidation is necessarily good. Mark Twain was knew that memories could be inaccurate. This quote, when I was younger, I could remember anything, whether it happened or not. But as I get older, I'm still only going to remember the latter. And he also said that what amazed him was not the things he did that he couldn't remember, but the things that he clearly remembered that he actually didn't do. And sleep can also facilitate the encoding of false memories. And so we all have false memories that we encode. And for young people in particular, we somehow find a way to accidentally encode those false memories during sleep. So whereas overall it's essential for memory, we have to realize that memory is very complex and it's prone to creating mistakes. Now, the changes in sleep in Parkinson's disease are really quite, a few different changes. There's sleep fragmentation, there's delayed sleep onset. There's some changes in REM sleep architecture, but the most prominent change in sleep that occurs with neurodegenerative disease is a decrease in stage N3 sleep. So the slow waves that we saw earlier, they start going down in amplitude even at the end of adolescence, and this decrease continues as we age, but it's accelerated in Alzheimer's disease and Parkinson's disease. It's associated with increased pathology, so if you look at a patient that has less slow wave sleep, their brain sample will show increased pathology on the autopsy, and it's associated with decreased cognitive function, including decreased memory. A recent study, this is better studied in Parkinson's disease patients than in patients with, or Alzheimer's disease patients than patients with Parkinson's disease, but it clearly occurs in Parkinson's disease also. A recent study of 140 Parkinson's disease patients found decreased N3 sleep, and this correlated with cognitive decline, including problems with memory. Parkinson's disease patients also have increased incidence of a variety of sleep disorders. And so we're going to talk about how this basic physiology, the N3 sleep being involved in memory formation, how this is relevant to Parkinson's disease and other neurodegenerative processes, and how we might be able to use this in treating patients with Parkinson's disease. First, I want to talk about natural sleep disorders. Since this is kind of the low-hanging fruit, we're pretty good at treating most forms of sleep disorders that occur in our patients today. 80% of Parkinson's disease patients have sleep disruption. 30% of those don't even bother to discuss it with their healthcare provider. So we're really not treating the sleep disorders in a lot of our Parkinson's disease patients. Insomnia is the most common complaint. Sleep onset is common earlier in the disease. Sleep maintenance predominates as the disease progresses. And the insomnia often predates motor symptoms of Parkinson's disease and becomes more severe as the disease progresses. A variety of primary sleep disorders occur in Parkinson's disease: obstructive sleep apnea, central sleep apnea, restless legs and periodic limb movements, REM sleep behavior disorder, and narcolepsy and daytime sleepiness all occur and can impact the ability of the Parkinson's patient to function well and to learn. We're going to talk about REM sleep behavior disorder at the end. REM sleep behavior disorder is where we act out dreams, and it's associated with a significant decline in cognitive function. So a Parkinson's disease patient that has REM sleep behavior disorder is more likely to have their memory impaired than patients that don't. However, treating the REM sleep behavior disorder probably doesn't improve function, whereas the treatment of these other disorders probably does. This is an example of a patient that has obstructive sleep apnea. And right now you can't hear anything because he can't breathe and sleep at the same time. And so this person is literally unable to sleep and breathe at the same time. And for sleep to be effective in memory consolidation, you have to go through that cycle with non-REM sleep, slow wave sleep, REM sleep, and then back to the beginning. The sleep cycle is completely disrupted in this person because he's only able to sleep in small increments, 30, 45 seconds at a time. So he's getting very little REM sleep, very little slow wave sleep, and wakes up feeling exhausted, unable to attend to tasks. And memory impairment significantly, memory consolidation significantly impaired. There's conflicting data on prevalence in Parkinson's disease, but it's probably more common than in individuals without Parkinson's disease. Motor control deficits contribute to the OSA, and so it's a little bit different than the obstructive sleep apnea that we see in other patients. Dopaminergic drugs may actually improve the sleep apnea in some patients, which indicates that the oscillations in the motor control probably affect breathing as well as other motor functions. And if you treat that, the sleep apnea may get better. Treatment may improve motor symptoms. And sleep apnea also worsens restless legs and RVD. So these different disorders interact with each other to aggravate each other. Parkinson's disease patients also are more likely to have central sleep apnea, and that's where the brain doesn't give a signal to breathe. We see a lot of that at this altitude just because of the thin air that we have. But dopaminergic drugs may also worsen central sleep apnea. Sleep apnea is associated with cognitive deficits in normal individuals, and these deficits are reversed with treatment. Executive functioning is probably impaired more than memory, which is impaired more than other domains. But it's clear that you do have deficits that are created by sleep apnea, and the deficits are reversed by treatment. In addition, people with obstructive sleep apnea, even normal individuals, show a shrinking of cortical gray matter. And that to some extent is actually reversed with treatment of the sleep apnea. So we can actually demonstrate functional consequences of sleep apnea on both gray matter and white matter that is reversed with treatment even in normal individuals. Sleep apnea appears to be even more associated with worse cognition in patients with Alzheimer's disease. And so patients who have sleep apnea at the same stage of Alzheimer's disease will have significantly worse memory than patients that don't have sleep apnea. In addition to this, there's recent work showing that obstructive sleep apnea is associated with increased risk of development of Alzheimer's disease in elderly people. So if you have a person who has sleep apnea and you follow them, they are at increased risk of developing dementia. And this is not a small risk. It can be as much as 70, 85% in some studies. And so a significant increased risk of development of Alzheimer's disease with obstructive sleep apnea. What does treatment of sleep apnea do? Some studies have shown there's a delay in the development and progression of symptoms in patients that have treatment of their sleep apnea. Most of these are not controlled trials, but there are some shorter-term randomized trials with CPAP and Alzheimer's disease, and these reveal a significant increase in stage N3 sleep and a significant improvement in cognitive function, particularly verbal memory. And so treating sleep apnea does two things in patients that have Alzheimer's disease. It improves cognitive function almost immediately, especially memory function, and it may actually delay the progress of the disease process. So it's important to think about this when you're treating patients with neurodegenerative processes. The data is limited in Parkinson's disease, but sleep apnea is generally associated with worse cognitive function, and there's a limited data suggesting that treating the sleep apnea for 12 months may actually result in an improvement in cognitive function rather than a decline that is seen in untreated patients. And so treating sleep apnea is really a low-hanging fruit when it comes to improving sleep in patients with neurodegenerative disorders because it's easily diagnosed, easily treated. There are problems that occur with patients with Alzheimer's disease and Parkinson's disease in terms of getting them to tolerate sleep apnea and other treatments for sleep apnea. But the treatments are quite effective and easily available. Parkinson's disease patients also are more likely to have restless leg syndrome. It's complicated by augmentation and rebound from dopaminergic drugs, and so management can actually be quite complicated. Treatment is with iron infusions, alpha-2 delta ligands like gabapentin. Over-the-counter sensory techniques can also be helpful. Most patients that have restless leg syndrome also have periodic limb movements. Periodic limb movements may be present without restless leg symptoms also. So always keep an eye out for a person that may have sleep fragmented because of periodic limb movements or restless legs. This is a patient that I saw who came into me saying that he hadn't slept in 10 years. And the truth is he was sleeping, but he would sleep in about 20-second increments. And so sleep was not really fulfilling any physiologically useful purpose for this person. He was exhausted, sleepy, mentally impaired by the lack of sleep because he was awakening every 10, 20 seconds, jerking his legs. He wasn't aware of it. His spouse was. But once this was treated, he was able to fall asleep and sleep normally and had a marked improvement in his function. Restless legs is associated with global cognitive deficits in Parkinson's disease. There's really no data on the effect of treatment on global deficits in Parkinson's disease patients with restless legs. However, since the sleep fragmentation that can occur with restless legs and periodic limb movements is on par with the sleep fragmentation that can occur with sleep apnea, I suspect that treating it will result in significant improvements, and we should keep our eye out for patients that have restless legs and periodic limb movements and treat it aggressively. Also improves the quality of life significantly in patients that have restless legs. Psychiatric disorders are common in patients that have Parkinson's disease. Depression is more common. It's associated with greater sleep complaints. And the treatment can be challenging. Medications can worsen restless legs, periodic limb movements, REM behavior disorders. So behavioral treatments are best if possible, and careful management of the side effects of the medications are essential if medications are necessary. Anxiety is quite common, understandably so. Then you have the direct effects of Parkinson's disease that interfere with sleep. You have tremor, gastroesophageal reflux, rigidity, pain, dyskinesias, akinesia, nightmare, hallucinations. All of these need to be assessed and addressed if you're going to have adequate sleep in a patient with Parkinson's disease. Long-acting Sinemet or dopamine agonists can be beneficial in managing some of the motor symptoms, however, can also cause dyskinesias and have a direct alerting effect. Rotigotine improves subjective and objective sleep, extended release pramipexole, ropinirole, and other extended release symptoms actually sometimes improve the quality of sleep. So we have to think not only about motor function in the daytime, but also motor manifestations of Parkinson's disease at night that can affect our sleep. Nocturia is common. They often have, as we get older, we develop a number of other medical disorders like osteoarthritis that can either directly affect sleep or indirectly affect it. We tend to have decreased activity level. Exercise, we'll talk about a little bit later, is one of the best things for sleep. And if you put a person in bed, even a young person, and ask them to stay in bed and not get up and move around, they almost immediately develop a fragmented sleep-wake cycle with difficulties consolidating sleep. We have decreased light exposure, we have decreased social interactions, and medications, and even the timing of medications can result in sleep fragmentation. Medications themselves can interfere with sleep. Levodopa, rotigotine, pramipexole, this is just a partial list, but we have to think about what we're doing to the patients that can actually interfere with the quality of their sleep and try to minimize the impact of this on sleep. And then there are circadian rhythm disorders. There's degeneration in the suprachiasmatic nucleus, decreased light exposure, and the dopamine agonists can actually blunt melatonin secretion, which is essential in our sleep timing. The amplitude of the rhythm is decreased. There's a relative phase advance that occurs with aging, but it's exaggerated with people with Parkinson's disease and other neurodegenerative disorders. And so there are a variety of issues that worsen sleep. And then there are a variety of sleep hygiene issues, increased time in bed, and a regular schedule, all reduce the efficiency of sleep in patients with Parkinson's disease. And like any patient that's having trouble sleeping, we tend to develop psychophysiological insomnia. That's where sleep becomes a concern. We begin to worry about not sleeping. Sleep becomes an arousal stimulus rather than a relaxation stimulus. And studies show that this responds to cognitive behavioral therapy in Parkinson's disease, just like it does in other patients. So behavioral therapy is important for a patient that's having problems sleeping that aren't due to a primary sleep disorder. There's very little data correlating insomnia and cognitive deficits in Parkinson's disease. In fact, there's very little data in any population demonstrating that you can improve cognition with treatment of insomnia, but treating insomnia improves the quality of life measures. And extreme insomnia, where people are getting less than 5 hours in bed, results in increased cardiovascular risk. And as we'll talk about, less than 6 hours in bed probably increases your dementia risk. So it's really important that we do treat insomnia in patients with Parkinson's disease while we're gathering more information about the effect on cognition. Excessive sleepiness occurs frequently in patients with Parkinson's disease, and they can develop frank narcolepsy. You get a degeneration of neurons in multiple nuclei that maintain alertness in the brain. You, of course, want to evaluate for the other sleep disorders that can cause sleepiness. And bright light itself has a stimulating effect, and so we don't expose ourselves to as much bright light in this industrial society. We're indoors with light that's much dimmer than outdoor sunlight, and so just simple exposure to bright light can be helpful. Modafinil and other stimulants may be helpful, and there are other drugs that are potentially helpful for daytime sleepiness in patients with Parkinson's disease. Excessive daytime sleepiness is associated with global cognitive deficits, and it predicts decline on follow-up in terms of memory and other neurocognitive tests. Pharmacological treatment improves cognitive function in other conditions. There's limited data in Parkinson's disease, but it probably one would expect that it would improve memory function just because you're able to attend better when you're not sleepy. There's really no evidence that treating it pharmacologically affects the long-term course of the disease. So seeing that N3 sleep enhancement or N3 sleep is essential for memory, the first thing we want to do is treat underlying sleep disorders, because all of those disorders we talked about decrease the amount of N3 sleep that we have, and they're fairly easily treated and can result in fairly significant improvements in cognition and memory. So treating the underlying sleep disorders is important. But what else can we do to enhance N3 sleep? Probably the simplest is exercise. Most studies have shown that if you get regular exercise, that you have increased quality of sleep, you have increased slow wave sleep, and there's some evidence that it delays the progression of neurodegenerative disorders such as Alzheimer's disease. So exercise is good in general. It's, again, one of the pillars of good health, but it also directly affects our sleep and directly affects our cognition. So exercise is important. There's some other experimental paradigms that might actually improve the amount of N3 sleep that we get, and we'll talk about those also. There's a lot more data on exercise in Alzheimer's disease, but this particular study followed patients with Parkinson's disease, and they did simple resistance exercises for 2 years and were followed. It was a randomized trial with a control group, and the patients that did resistance exercises, their cognitive status was maintained, whereas those that didn't had a significant decline. So there's some limited data that exercise improves cognitive function in Parkinson's disease. Auditory stimulation is a new experimental method that's been shown to actually improve slow wave sleep or increase the amount of slow wave sleep. And what they do is they give a brief auditory stimulus. It's not enough to cause a cortical arousal, so the patient's completely unaware of it. But when appropriately timed, it actually increases the amplitude of slow waves and increases the amount of slow wave sleep that people are getting. There are 1 nap study and 5 overnight studies that were performed. Verbal declarative memory was improved in 5 out of 6 of those studies, and 4 out of 5 of the studies found a clear correlation between the increase in slow wave activity and memory impairment. So something as simple as exposing a person to auditory stimulus during the nighttime to enhance slow wave sleep, it can actually improve memory function in humans. And it should be noted that these are patients that are normal, or these are subjects that are normal. They're not patients that had a degenerative disease. But a simple manipulation of stage N3 sleep actually results in measurable improvement in memory, which is actually a pretty stunning finding. Another way to manipulate sleep is through transcranial current stimulation. This might sound horrible, but it's a very low low current that's applied, and we actually do use application of current to treat insomnia. But if it's timed appropriately, you can actually increase the amount of N3 sleep that a person gets and increase the amplitude of the slow waves and the size of the slow waves. 5 out of the 12 studies found improvement in verbal declarative memory when this occurred. So it didn't seem to be as effective as the auditory stimulation. But again, manipulating slow wave sleep activity actually was found to improve memory in normal subjects. Pharmacological agents are a little bit more disappointing. It should be noted that just because you see slow waves on an EEG, that doesn't mean that you're actually recreating or increasing the amount of stage N3 sleep that a person's having. Slow waves are a manifestation of encephalopathy, and memory integration and learning is almost impossible in encephalopathy. But on the other hand, there are some medications that do appear to actually increase stage N3 sleep, such as sodium oxybate, which there are a number of reasons when you look at it to think that it's actually increasing the amount of physiological slow wave sleep. Despite this, 8 of the 9 studies that found increased duration of N3 sleep, none of them really found an increase in slow wave activity, which is the amplitude of the waves and the frequency of the waves, rather than just measuring technically it being a stage of sleep. And only one study found improved verbal declarative memory, and that was with interleukin 6. And one study found that with sodium oxybate showed that the efficiency of sleep that you're getting seemed to be improved when you used sodium oxybate, but it really didn't improve memory per se. It just reduced the deficits caused by a sleep deprivation paradigm. So pharmacological augmentation of sleep has been rather disappointing, and that's what we found with a lot of our pharmacological studies on sleep in general. It's much easier to show that you have impairment from sleeping pills than to actually show that you have improvement. But as we learn more about sleep and have more pharmacological options, this may change. Now I want to move on to sleep and structural damage. And CNN just reported this study. 8,000 individuals were followed for a mean of 24.6 years. Sleep duration was measured by questionnaires, with some of the patients also receiving actigraphy, which is like a Fitbit, measures whether you're awake or asleep. Individuals with a sleep duration less than 6 hours at 50, 60, and 70 years of age had a 30% increased risk of developing dementia. And this is just the most recent study that shows that if you're getting less sleep than you should, you're at increased risk of developing dementia. This is not proof of causal relationship. Our work at Washington University showed that patients with Alzheimer's disease developed insomnia decades before they developed other signs of Alzheimer's disease. And it could be that that's just the first manifestation of Alzheimer's disease. However, the consistency of this finding suggests that if you're not getting enough sleep, you are probably at increased risk of developing Alzheimer's disease because of the sleep deprivation itself. That raises the question of how does decreased sleep lead to structural damage? Well, for one, if you're awake, parts of the brain have persistently elevated neuronal activity levels that may increase levels of toxic metabolites. There's increased free radical oxidation that occurs. There's increased dopamine release that can be neurotoxic, at least the metabolites. So the direct result of wakefulness may be toxic to the nervous system. Probably more important is the recently discovered lymphatic system. It's analogous to the lymphatic system for the periphery. The lymph system drains substances from the body that the body wants to clear. The lymphatic system drains toxins from interstitial fluids through the perivascular spaces. And so astrocytes form these water channels that go to the perivascular spaces that remove toxins and metabolites from the brain. This is regulated by sleep. The interstitial fluid expands by 60% during sleep, and lymphatic clearance of toxins doubles during sleep. So if we don't get sleep, we're not going to get the clearance of toxins that we need. Sleep deprivation may be critical in this. We have a lot of data on Alzheimer's disease and lymphatic clearance. Amyloid beta accumulates in the extracellular space. It's a hallmark of AD. Interstitial AB is cytotoxic to neurons. And the accumulation of amyloid is probably the critical event in the pathogenesis of Alzheimer's disease. Aggregation of AB is normal AB is a normal substance, but the aggregation of it into abnormal clumps of the protein is what leads to the plaques in Alzheimer's disease and what appears to be toxic. And it's a concentration and time dependent process. So the level of amyloid in the interstitial space correlates with neuronal activity. The plaques are highest in the brain regions with the highest neuronal activity, and particularly in the default network, which is always active, it's prone to the development of plaques. In vitro microdialysis experiments in wild type and human transgenic mice show that there's a variation in amyloid. The amyloid levels increase when the mouse is awake, and they decrease when the mouse is asleep. The correlation is strongest with non-REM sleep, so the amyloid levels go down during non-REM sleep in particular. The rhythm persists in dim light conditions, so it's due to sleep itself. Sleep deprivation for 6 hours leads to significantly higher amyloid levels in mice. Orexin, which increases alertness, increases amyloid levels. Almorexant, which is similar to the medication Balsama, reduces the amyloid levels. If you restrict them for 20 hours, they had a significantly greater plaque formation compared to animals that weren't restricted. Amilorexant treatment, which increased sleep for 8 weeks, decreased plaque formation. When you look at the mouse models, reduction of 20% in the amyloid levels blocks plaque formation. And behavioral interventions such as sleep and pharmacological manipulations result in a 20 to 25% reduction in levels, even in humans, and could be clinically significant. This is an example of a mouse brain. The left one is one that's not sleep deprived. The right one is one that is sleep deprived. The black spots are all the Alzheimer's type plaques that are occurring. So sleep deprivation, at least in an experimental model of mice, leads directly to the increased accumulation of amyloid and the increased formation of plaques. This has been studied in humans. When I was at Washington University, we were involved in a study in which 10 healthy normal volunteers had a lumbar catheter for 33 hours. The CSF was sampled, and there's a clear fluctuation throughout the day. Amyloid levels go up when a person's asleep, or go up when a person's awake, and they go down when the person's asleep. And so sleep reduces amyloid levels in the CSF of humans, like it does in experimental animals. And presumably, the more clearance you have of amyloid in humans, just like in mice, will reduce the plaque formation. And so the model is that fragmented sleep leads to increased neuronal activity, increased amyloid release, decreased lymphatic clearance, which leads to increased amyloid deposition and worsening disease in patients that have a predisposition to Alzheimer's disease. So this leads to the next question, which is why not just give sleeping medications? Well, unfortunately, most sleeping medications adversely affect memory. Most medications worsen sundowning. Most medications increase the risk of falls and nocturnal wandering. Most worsen the risk of sleep apnea. But probably more significantly and most disturbingly is that most hypnotics have been epidemiologically associated with the increased risk of Alzheimer's disease. And again, this doesn't prove causality, but does give you pause to think that maybe sleeping medications, which don't seem to increase the physiological slow wave sleep, may actually not be a beneficial thing. It could actually be harmful. And so we really need more work on medications and whether your typical medications that we use to treat insomnia and sleep problems actually do result in improvement or worsening of the risk for Alzheimer's disease. The clearance of alpha-synuclein by the glymphatic system, unlike Alzheimer's disease, has not been demonstrated in Parkinson's disease as in Alzheimer's disease, at least not to my knowledge at the present time, although I'm sure there are people working on that at the present time. But there is a negative correlation found between aquaporin 4, which is the ion channel or the water channel in astrocytes, and alpha-synuclein deposition in experimental animals. And so there is a link between the health of the lymphatic system and alpha-synuclein deposition. And in experimental animals, if you disrupt the lymphatic system by ligating the deep cervical lymph node, alpha-synuclein deposits increase in neurons. And so it does appear, at least circumstantially, that the lymphatic system is essential for clearing alpha-synuclein. And if you don't clear it, at least increased deposition and presumably a worsening of Parkinson's disease and the neurological consequences of it. The final topic I want to cover is REM sleep behavior disorder. And this is a patient that was diagnosed as having Alzheimer's disease. And we didn't know that he had dream enactment behaviors. He's dreaming that a Russian torpedo boat is attacking his ship. And so what do you do when you have a Russian torpedo boat attacking your ship? You jump out of the ship, which is what he was dreaming about here. Luckily, he was diagnosed with REM sleep behavior disorder. We were able to treat it. And we're able to prevent any further trips to the emergency room. He had been jumping out of bed multiple times a month and going to the emergency room to be sutured up. And this was, it didn't make me happy that he jumped out of bed in the sleep lab, but that was the last time he had injured himself since we treated it effectively. So REM sleep behavior disorder is common in patients with Parkinson's disease, and probably more significantly, though, from the standpoint of memory, is that the majority of patients, when they present with REM sleep behavior disorder, many of them do not have symptoms of Parkinson's disease or other neurological disorders, but there's a strong tendency to progress to neurodegenerative disease, mostly Parkinson's disease, Lewy body dementia, MSA. And so the onset of RBD symptoms often precedes other manifestations of Parkinson's disease by years and even decades. So when a patient presents with REM sleep behavior disorder, they may have no impairment of memory, no other Parkinson's disease symptoms. And by identifying those patients, that gives us the opportunity to allow early intervention and test therapeutics. And as a final statement, this is a new program at the University of Colorado, the Parkinson's Progression Marker Initiative. It's a worldwide initiative to try to develop a process to identify people that have risk factors for Parkinson's disease, to develop a database to determine what leads to the progression, and to develop a database for the potential testing of new therapeutics. And we're excited in the sleep field to finally have a program like this, because for about 30 years now, we've known that patients with REM sleep behavior disorder would often go on to develop a neurodegenerative syndrome. And if we can identify them early, we can preserve cognitive function and memory once we have effective therapeutics that we can use to intervene in the degenerative process. And so in conclusion, I'd just like to say that sleep plays an important role in memory and brain health. Sleep deprivation and sleep disorders leads to functional memory and other cognitive deficits. Sleep deprivation and sleep disorders may accelerate neurodegenerative processes. Treatment of sleep disorders improves memory, especially in sleep apnea, and may actually delay the progression of neurodegenerative diseases. Simple methods of augmenting sleep may someday provide interventions to improve memory. I'm not sure how many people will want to have their brain subjected to electrical stimulation every night, although it's harmless, but certainly an auditory stimulus providing increased cognitive function is a very simple thing to do. So although these are simply in the experimental stage now, it's proof of concept that very simple interventions to increase slow wave sleep can actually provide improvement in function. And someday we may actually be able to increase certain stages of sleep by particular protocols, and thereby improve memory function in patients that have impaired memory, or even in normal individuals. And finally, identification of patients with REM sleep behavior disorder provides an opportunity for early intervention. And we are now at the point where we're going to be taking opportunity to use this for identifying better understanding of Parkinson's disease, and hopefully testing therapeutics to intervene decades before they develop other neurological manifestations of the disease. So it's a very exciting time in the sleep field when it comes to the interactions with neurological disorders such as Parkinson's disease, because we may actually be able to have a significant impact on the well-being of our patients and their cognition and memory function. So at that point, I'll go ahead and open up to any questions that people might have.
Sorry, I'm a little too fast on my mouse there. I keep turning myself back off. So thank you so much, Dr. Duntley. We do have a couple of questions. The first one is from Brian Hyde. The question is, is there any research on benefits of exposure to nature, maybe including moving water or exposure to music, in improving sleep for people with PD?
I'm not aware of it specifically in relation to PD, but exposure to nature usually involves exercise and exposure to light, outdoor light. And there's definite evidence that improves sleep in general. Music therapy is actually an interesting field of insomnia research right now. And there are a number of trials on music research or music exposure to help with insomnia. And it can be beneficial. Other types of noises have been less studied. However, a variety of noise programs that you can get on phone apps help different people sleep. And so I would expect that the findings in Parkinson's disease would be similar to the findings in other disorders in normal individuals with insomnia, And anything that improves sleep is going to improve function, and exposure to nature and exposure to music are two of the things that can help. Now, the particular type of music hasn't been well established, but there are clearly protocols where music improves sleep.
Okay, thank you. And then from Kirk, do white noise generators have any impact on sleep?
White noise generator, yeah, it's kind of similar to the other one. White noise generators help some people sleep, particularly when they're masking other noises, masking tinnitus, or masking or just simply soothing for some people. Other people find them annoying, and any noise at all bothers. So that's one of those things that falls in the category if it helps you sleep, do it. It's not the type of noise that would be specifically timed to increase the elements of sleep, but at some point in the future, there may actually be noise programs that are utilized that monitor the brain activity feedback, are used to augment the actual brain waves that occur during sleep to improve the effectiveness of sleep. Right now, it's just used if it's helpful in a person sleeping because of other reasons.
Okay, all right, thank you. From Eric, how is RBD treated?
REM sleep behavior disorder is treated by, first of all, assessing for sleep apnea and other sources of sleep fragmentation, such as periodic limb movements. It's surprising how many patients, when the sleep apnea is treated, can have a resolution or a marked improvement of their REM sleep behavior disorder. If that's not effective, there are three main categories of medications that are used. The first that we usually go to now is melatonin. I particularly like life extension melatonin because that's what our researchers use on upper campus because it's pharmaceutically pure. And often a combination of immediate release and sustained release anywhere in the 3 to 12 milligram dosage range. We choose that because it tends to have fewer side effects. It's effective in many patients, doesn't worsen sleep apnea, doesn't worsen cognition in most patients. So that's our first line treatment. The single most effective treatment is probably clonazepam, which is a benzodiazepine that is remarkably effective in most patients. It has other problems. It can impair cognition. It can increase the risk of falls, but sometimes that's the only medication that can be used that's effective. And then dopamine agonists, such as pramipexole, can be very helpful. And sometimes in patients with severe disorders, we have to use all three. And then there are a handful of medications that are sometimes used, like sodium oxybate. But most patients we can effectively treat.
Right, terrific. And Sue had sent in a question about melatonin, but I think you just answered that as part of that question. So Sue, okay, if you have a specific question or need a follow-up, let us know. But I think Dr. Duntley just answered your question. The next question is from Kent. Any connection between sleep deprivation and speech issues in PD?
I'm not aware of specific research on that. There may be. If there is, I have not encountered it. But motor function in general can improve with treatment of with improved quality sleep. And cognitive function improves the sleep, and speech is a combination of those two. So I would think that there'd be some impact of improving sleep on speech in general, but I'm not aware of the specific research being done. But that would be an interesting topic to look into.
And from Fern, auditory stimulation such as leaving music on during the night or white noise music, and I think you've answered that. Is there anything else that you wanted to share about maybe leaving music on at night? I know you just said the white noise.
Yeah, it's kind of the same. The thing important is to not leave something on where the programming changes significantly enough to actually wake you up. So if it's a program that plays the same thing over and over again that you find relaxing, that's probably okay. White noise that's constant is okay. If it's like a radio station that's going to change from one type of music to another, that can be disruptive of sleep. And so we generally would want a person to avoid that, or to put it on a timer so it goes away during sleep.
All right, and then should exercise be at a particular time of the day to help with sleep, or maybe multiple shorter sessions of exercise throughout the day?
Yeah, I mean that's probably there's evidence that exercising at different times of day can have different effects on the circadian rhythm. There's evidence that exercising in the morning might be a little bit more prone to cardiovascular accidents because the blood pressure tends to be highest in the morning to begin with. And if you if you exercise too close to bedtime, it can be an arousal stimulus. I think the only really thing that's significant is if you exercise too close to bedtime, it may interfere with your sleep onset. Other than that, I think the important thing is to get exercise. And I don't think there's any good data that any particular time of day is better for the average person that's important enough to dictate whether you get exercise or not. You want to get it when you can. Most of us don't get enough exercise, especially in this COVID era. It's been almost impossible. Winter in Denver combined with COVID has been a real challenge for people getting exercise. So if you find that a particular time of day does interfere with your sleep, avoid it, particularly right at bedtime. But the most important thing is just and
Okay.
exercise outdoors has the added advantage of exposing you to bright light, which in and of itself helps with sleep. Exposure to bright light in the daytime increases the amplitude of circadian rhythms.
Okay. And I'll take this quick opportunity to remind people that we do have a lot of our exercise classes available on Zoom. So please, there's always a way to find a way to exercise. So the next question I have is from Paul. Is the audio stimulus you talked about to improve N3 available to the general public?
No, it's not. It's specific, at least not to my knowledge. I'm always amazed how quickly these things are turned into apps. But it would require an electrode to monitor brain activity, process it, and then deliver the stimulus. I'm not aware of that being commercially available, but then again, I haven't specifically looked for it. I suspect that it's a ways off before it's going to be in widespread application. But there is a lot of research right now going on sleep augmentation. And it is actually exciting. Things are picked up so quickly in the private sphere now that I suspect it won't be long before things are available.
Oh, that's great. Okay. How much variability is there among individuals? Do some people do fine on 5 hours of sleep?
Well, that's yes and no. The epidemiological evidence is that if you get 5 hours of sleep, you're at higher risk of a number of adverse health consequences. So most of the studies show a U-shaped curve. If you sleep too little, you're impaired. If you sleep too much, you're impaired. The increased sleeping too much is probably because we're not adequately controlling for other sleep disorders like sleep apnea. So from just an epidemiological basis, you are at increased risk if you sleep 5 hours a night. Now, from a clinical standpoint, I have patients that come in and say, I do fine on 5 hours. Sleeping more doesn't help me feel any better. And right now, from a clinical standpoint, we tell people that they need enough sleep to feel fully refreshed. And sometimes trying to get them to sleep longer can only give them side effects. And so if a person really is fully refreshed and not the least bit sleepy, not the least bit fatigued, not the least bit impaired on 4 hours sleep, I don't have good evidence that that particular person can be improved by sleeping longer. So there probably is a bell curve of sleep need. We do not know what the markers are that we need to measure to identify those patients that are actually not getting enough. So that's an open question at the present time. Clinically, I would say that you need enough sleep to feel fully refreshed, but at some point in the future, we might need to change that and say, nah, you really do need to get more than 5 hours.
Okay. We're just at 10:40, but I think a lot of people are going to want to hear the answer to this question, so I'm going to ask it very quickly. Does napping during the day offset a lack of nocturnal sleep?
To some extent, yes. Depends on how much sleep deprivation you have and how long the nap is. For most individuals, we were actually designed to take a nap. And so we should be taking a nap. The Latin societies that took the siesta definitely got it right. That we have that slump in the afternoon for a reason. It's to remind us to take a nap. The brain can maintain maximum efficiency for only about 10 hours, and after that, it's even a brief nap of about 30 minutes is refreshing. So that 30-minute nap helps maintain brain effectiveness during the daytime, but it probably doesn't make up for significant sleep deprivation at night. And so if you are, for instance, only sleeping 4 hours at night, then a 3-hour nap in the daytime may actually accomplish the same thing as the 4 hours at night. The sleep stages are distributed differently. You don't get much REM sleep in the daytime, so we don't know whether it's really going to be as effective as nighttime sleep. But a brief nap in the daytime is generally a good thing. A longer nap, if necessary, because you're not able to sleep long enough at night because of work requirements or something else, would be recommended. But in general, it's probably better to try to get the bulk of your sleep at night.
Okay. Thank you so much, Dr. Duntley. I know that was a super informative presentation, and my takeaway from that, and I hope everyone else saw that, is how important it is to discuss any type of sleep disruption you're having with your healthcare provider. The fact that 30% don't have that discussion is not a great percentage. So I think you really need to focus on that. But I really do appreciate your time, and to learn